Hi, this is Zach Fulkerson with the Critical Care Curriculum, and this is our second lecture on shock. Of course, the first lecture we define shock as well as discuss the different types of shock. And before we get into the management of different shock states, I wanted to briefly go over vasopressors and inotropes. So let's get started. Before we discuss the different medications, I want to discuss the receptors that these medications act on. So we have adrenergic receptors. These are the alpha and the beta receptors, and they respond to molecules kind of like adrenaline. That's why they're called adrenergic. So adrenaline or epinephrine. We have vasopressin receptors as well as angiotensin receptors that we will also briefly talk about, but really the bulk of this talk is going to be about the alpha and the beta receptors. Beta 1, mostly located in the heart, and when we activate beta 1, that causes either inotropy, so increased contraction of the heart, or chronotropy. So, of course, we're going to use this mostly in cardiogenic shock and cardiogenic states. The beta 2 receptors are going to be located in the arterioles, and they cause vasodilation. Note that they're also in the bronchioles, and so albuterol, which is a beta 2 agonist, an inhaled beta 2 agonist will cause bronchodilation in states like asthma. An alpha-1 receptor, again, also mostly located in the vasculature and the arterioles, that's going to cause vasoconstriction. And most of our agents that act on one of these receptors kind of have some overlap with the other receptors as well, so we will be discussing that. Vasopressin, that's going to act on the vasopressin receptor, and angiotensin is going to act on the angiotensin receptors. Both of those cause vasoconstriction. I like to simplify things. I like to think of my alpha receptors as causing arterial vasoconstriction, and I like to think of the beta receptors, of course, causing inotropy and chronotropy. Since beta agonists will usually cause some sort of vasodilation as well, you may hear these referred to as inodilators as well. The side effects of these usually depend on how much alpha and how much beta there is. So, for example, alpha agonists can cause decrease in splenic perfusion and decrease in extremity perfusion. So you can actually get digital ischemia from decreases in perfusion with alpha agonists. On the contrary, the adverse effects of beta agonists usually include tachyarrhythmias, especially atrial fibrillation with rapid ventricular response or atrial fibrillation with RVR, and they can also cause an increased myocardial oxygen demand, and in states such as acute coronary syndrome, that's not necessarily what you're wanting. Now, of course, they can cause dilation, so beta agonists can also cause hypotension. A pure alpha agonist can cause a reflex bradycardia. So those are some other side effects that you're going to have to be aware of. All right, let's get into the medications. So which medication has purely alpha receptor activity? Is it norepinephrine? Is it isoproterenol? Is it dopamine? Or is it phenylephrine? So if you guessed phenylephrine, then you would be right. So getting back to our diagram over here, phenylephrine has purely alpha activity. That means it acts only on the arterioles and causes pure vasoconstriction. It doesn't act on the heart at all, but because it causes pure vasoconstriction, there can be a reflex bradycardia with phenylephrine. Now, if we move to stuff with slightly less alpha but a little bit of beta, we get norepinephrine. This is probably the most common pressor that you will be using in the ICU. Norepinephrine has mostly alpha, so we use it in distributive shocks a lot. But it's got a little bit of beta, so it doesn't have the reflex bradycardia and maybe the decreased cardiac index because of the increased afterload that phenylephrine has. So we tend to use this as a first-line pressor for things like septic shock. Next, we have epinephrine. Epinephrine actually does have quite a bit of alpha, but we're also getting more beta. So epinephrine will cause a little bit more inotropy, a little bit more cardiac squeeze. Next on our list, we've got dopamine. Dopamine has different activity depending on the dose that you're using. So at very low doses, you're going to have basically dopamine receptor activity. This This causes renal artery dilation, although we don't really use it for that anymore. That's something archaic that we used to think would help with kidneys. It doesn't really anymore. And as we increase, we start to get beta receptor activity. So a low dose of this you might use in someone with bradycardia. As we get to higher doses, we get more towards the alpha. Now, as we shift over this direction, we're going to have more problems with tachyarrhythmias from some of these medications. As we get to the predominantly beta-driven things, we have dobutamine. So this is one of our first-line medications that we use in patients with cardiogenic shock, where we're trying to help with cardiac squeeze. Again, it has very little alpha activity, so there can be some hypotension caused by dobutamine because of the beta-2 activity, the vasodilation. Again, we're kind of getting into the inodilator range. And then finally, we have isoproterenol, which really helps with chronotropy. It will help the heart to squeeze faster, but again, can cause some hypotension because of vasodilation. All right, that does it for the adrenergic receptors. Real quick, even though the next lecture is more of management, is which is the first line for septic shock? Is it norepinephrine, isoproterenol, dopamine, or phenylephrine? So the answer here is, of course, norepinephrine. It's not phenylephrine, and that's because we don't like the bradycardia and the possible decreased cardiac index that comes with phenylephrine. So our first line for septic shock is norepinephrine. And again, here it is on the chart here. Norepinephrine predominantly is going to increase the systemic vascular resistance, but isn't going to drop our cardiac index a lot like phenylephrine will. Again, those are the adrenergic receptors. We also have vasopressin receptors. This is usually a second-line agent in adults for septic shock, as well as angiotensin receptors. And there is a newer medication called angiotensin 2, or Giapreza, which acts on this receptor. We don't have a lot of data for this, so this is not used quite as much as some of the other pressors, just because it is so new. We have very little data on it. And, of course, it is very expensive as of this recording, which is $2,000. I'm going to briefly talk about milrinone. Milrinone is another medication that is used in cardiogenic shock as an inotrope, and what it does is, instead of acting on a beta receptor, so beta receptors increase cyclic AMP, it actually blocks this receptor, so it blocks the breakdown of cyclic AMP, and it keeps the cardiomyocyte active. So it is an inotrope. It is thought to increase the myocardial oxygen demand a little bit less than dobutamine, so that might be one advantage. But of course, just like the other ones, it can cause some hypotension because of the peripheral activity. That does it for vasopressors and inotropes, and in the next lecture, we're going to be going into the management of different shock states.